Dr. Diana, Dr. Lim, it's 3 p.m. Probably we'll give maybe about another 30 seconds or so for the audience to come in, then we'll start. That's okay? Okay. Perhaps we can start now if Dr. Diana and Dr. Lim are ready. Okay, great. Good evening to everyone in attendance. Welcome to our third week of our palliative care webinar series organized by the College of Physicians Malaysia. Today, our topic will be on palliative care with regards to respiratory illnesses, something that we commonly see in secondary care and also in tertiary care as well. With us today, we have got Dr. Diana Fatiman and Dr. Lim Shusian, our chairperson and speakers respectively. They have been very supportive of our webinars since we started. Okay, so a little bit about Dr. Diana. She is currently a senior lecturer and also a consultant in palliative medicine and the head of the palliative care unit in Hospital Al Sultan Abdullah, UITM. She graduated from the National University of Ireland in 2003, subsequently obtained her master's from the University of Malaya in 2011, and completed her fellowship in palliative medicine in 2018. She is widely published, having published both locally and internationally as well. And she has got many professional involvements, of which some include sitting on many national technical committees dedicated to improving the palliative care services in Malaysia. And she's also the external reviewer of many local and international journals in relation to palliative medicine. So, Dr. Diana, I would like to hand over the floor to you.
Thank you so much for the kind introduction. Assalamualaikum and very good afternoon to everyone. Thank you for joining the College of Physicians weekly palliative care webinars. So I am happy to introduce you to my friend and colleague, Dr. Lim Shusian, who's a palliative care physician at HKL and also covers the IPR. She's received her training in palliative care locally and also in Singapore. And I'm sure she's the right person to share with you about palliative care management in respiratory illnesses. With that, I give the floor to you, Dr. Lim.
Thank you, Dr. Diana. Always a joy to see Dr. Diana. Okay, so a very good day. My name is Shu Xian. I'm a palliative physician and also an internal medicine specialist in Hospital Kuala Lumpur. Today, I will talk about A Tale of Three Men, palliative care in respiratory illnesses. So this is the agenda for today. First of all, we will talk whether there is a role for palliative care in respiratory diseases, and also how does palliative improve quality of life. Next, we will talk about why making plans is important, and we will end with a summary. I've used this picture a lot, but until now, this is still the same situation, although slightly less. That sometimes when the general ward sees us coming in, they really think that we are the death angels. We hope to change this so that the next time when people start seeing us, they will see us as happy and smiling angels. We all work very hard and we all try to do our best. We became doctors and nurses, hoping that we can save the world. However, this is not very true, and ultimately, everyone will have to pass away at some point or other. The ideal doctor, according to patients, this is what they want. They want someone to listen to them. They want someone who is competent and aware of the latest guidelines. They want someone who focuses on them, not just listen and then multitask and do something else. Sometimes it feels like a woman looking for a husband. They want your total and full focus, including the whole body, the eye contact. Yeah. But most importantly, they want their preferences and their priorities to be part of the management plan. It's very hard to achieve and also very possible to achieve. So palliative WHO definition has been there for very, very long. It's an approach that basically just improves the quality of life of patients and their families for those who are facing problems associated with life-threatening illness. So these are people who has, in the context of today's talk, these are people who have chronic respiratory illnesses. And a lot of people associate palliative care with lung cancer and cancer alone. However, that is undermining the palliative care team. We also see many patients that has chronic respiratory illnesses, such as COPD, ILD, etc., etc. And how do we improve their lives? What can we do? We try to prevent, and if suffering has occurred, we try to relieve by early identification, impeccable assessment, treatment of whatever that they are going through. In simple terms, palliative care is helping the patient and their family to live as well as possible for as long as possible. We start coming in even at the beginning. The dream that we all have is that everyone knows a bit of palliative care. It's like diabetes and endocrinologists. The endocrinologist hopes that everyone will know how to manage diabetes, then they can focus on the more complex ones. That is our dream too, that everyone will know a bit of palliative care so that at the early diagnosis of the disease, everyone can provide some care so that we can focus on the complex ones and also focus on those that need more of our attention. So we start seeing, even though from the beginning, though not much and not many, and subsequently as the disease progresses, the role of palliative care escalates. And we also start to take care of those who need bereavement. In our current setting in Hospital Kuala Lumpur, because of resource problem, hence we need to identify the ones with red flags, and those we will do bereavement care. So coming to our first gentleman, his name is Mr. Joe. He's a 65-year-old engineer. He just retired. He has 5 beautiful girls. Although we call them girls, but they are all grown up, all established in their careers, doing well, and they are all married and have children. Mr. Joe had a dream. His dream is to travel around the world with his wife. Probably he watched the show Travel Around the World in 80 Days. So he just retired and he was planning to start the trip in Spain. Unfortunately, things did not work out as planned. When I first saw him, I saw him in the hospital lying down in a bed. He had lung cancer. He was shouting and crying. The reason my team called me to see this patient was because he was asking for euthanasia. He was asking them to help him die as soon as possible, as he can no longer accept this suffering. When I arrived, this was what I saw. I saw a very distressed patient, a very distressed family, and a very distressed team of doctors and nurses. After sitting down with him, this was what I found. He was in severe pain. And the pain was so bad that he wanted to jump down the building. He was in the 2nd floor. I doubt he will really pass on, but it will definitely worsen the situation if he really did jump. And he was so frustrated. To worsen the situation, he was so scared of morphine. He felt that taking morphine will make him a drug addict, will make him bedbound, sleep even more, and will also make him pass away faster. So I sat down, found out where the pain was, explained about morphine to him, and also clarified all the myths of morphine. And he finally agreed to start to take morphine. We titrated the morphine as fast as possible, as safe as possible, and the pain was controlled. And the greatest joy that the palliative physician can achieve is that seeing our patients who are suffering starting to smile and continue their lives. So Mr. Joe continued his chemotherapy. So when someone asks me why I do palliative, in simple terms, I will say it is fun. But honestly, it is these joys that make it meaningful. So coming to his second visit, again, my team called me in because he was again in pain. However, this time was interesting. He was more frustrated and angry. And although there was real physical pain, but this time he was more vocal. And again, he was asking for euthanasia. There's a slight difference this time. He started to ask, why me? Why not other people? And this was his justification. I'm a good man. I've never done anything wrong. Why me? God, how can you be so cruel to me? These are very true things that our patient goes through. And this is what we call as total suffering. He has the physical pain that caused him to be so frustrated and so painful. But this second time, the emotional, the frustration, the anger, the depression, the spiritual frustration was worse. He started to ask these questions. God, what is the meaning of life? Is there a God? Is there a way to overcome this situation? So how can we help him? Are we able to change his situation? Are we able to remove the cancer from him? I'm purely a man. Let me rephrase that. I'm purely human. Only God can do that. But what we did was we journeyed with him together. We controlled the physical pain, helped him sleep better, and also lend him a listening ear. We started to teach him coping mechanisms and started to journey with him together, and he became happier. The cancer didn't go away, and he already used up all the options for chemotherapy. However, Mr. Joe still managed to overcome the multifaceted suffering, and he was at peace. And he could spend time with his loved ones, which are his wife, his daughters, and his son-in-laws, and also his grandchildren. I learned a very important lesson that day. Empathy sometimes really is the most important thing when we care for patients. Let's watch a short video to learn about empathy.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here. And you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So even as I am watching that video, it reminds me of Mr. Joe. I remember every single thing that he said to me. And I also remember him crying. And I also remember the relief that I saw in his face. And when he accepted, and even as he go through, there will be up and downs because we are mere humans. So it's very important for us to remember to include empathy in our daily practice. Because patients come here, they are truly unwell. And a kind word, or even just a listening ear, makes such a big difference to them. So if anybody wants to know why I do palliative care, it's the joy when we see patients improve. Not in terms of getting well back to their normal self, but in terms of them living as well as much as possible until it is their time to go home. So this is a landmark paper that was published in 2010. So we call it a landmark paper. It's not new anymore. That was written by the Tamel et al. So it talks about early referral to palliative care for patients with metastatic non-small cell cancer. And this was what they found. It wasn't surprising that we know that those patients who had cancer had depression. And the intervention arm were patients who were receiving the usual care plus palliative care. They were immediately referred to palliative the moment they were diagnosed. The control team was the usual care. If there were needs, then only the patients will be referred to the palliative team. So here we can see that there is a significance in reduction of depression. Even in the charts, we can see that blue color, which is the usual care, their depression and anxiety scores were really low, were higher in the usual care versus those that receive standard palliative care. So the next slide actually shows that patients with had lesser aggressive EOL, end-of-life care. When we talk about aggressive EOL, we are talking about less patients that are getting CPR, less patients getting intubated unnecessarily, and also less hospital admissions, less chemo when we know they are dying. The next part, this is the most interesting thing in this table, is that this study showed that those who had palliative care referred upon diagnosis, there was a benefit of survival of 3 months. That's why it's such a landmark study. It's not new. It was in 2010. That's 14 years ago. Hopefully, this paper and many other papers will continue to prove the importance of palliative care. So as Diana mentioned just now, I am in HKL, and this is the IPR palliative collaboration, where our team goes to IPR to see the patients who need our services. This includes patients who has lung cancer, COPD, ILD, be it IPF, or patients who even have MND. So this is how we try to help patients. And we go there when there is an inpatient referral, and also when there is a combined clinic, which is held twice a month. This is the warriors of IPR palliative team. So what's the benefit of combined services? It improves the patient experience. It reduces unnecessary hospital and clinic visits. They don't have to come on 2 separate occasions to see 2 separate teams. They can make 1 trip and they see 2 teams and whoever else that needs to be seen. The ideal multidisciplinary clinic will include the physiotherapist, the occupational therapist, the social worker, the psychologist, the volunteer support group. That would be a perfect combination, which is what we are working on. And coming to hospital is not easy. We're talking about journey. We're talking about the patient and family preparing to come. A lot of these patients are already very weak, very tired, and requiring a lot of oxygen support. So it's not just take your bag and go. And in KL, there's traffic jam, there is parking issue, and from one place to another place, from the car park to our clinic is not near. So hence, when we have a combined clinic, we reduce this, and a lot of patients definitely appreciate it. Every time they come to the hospital, the patient or the family who accompanies them may have to take leave from work. So how many times can a family or the patient keep taking leave? Let's say there's 4 TCAs a year, 4 clinic visits a year, and there's 2 teams. So 4 per year times 2 teams is already 8 times they have to come to hospital. If 8 times and the company doesn't allow accompanying family kind of time off, then it is 8 days of annual leave. So hence, having a combined service can reduce the economic burden to the patient and their families, and also to the system, because all you need is 1 registration team, 1 pharmacy to provide the same services, and you do not need separate teams. Hence, this is a more effective multidisciplinary care. And in HKL, we have quite a few combined services. Another of our combined services is the renal palliative care. So this is the Wish Trolley project. This was a project that was funded by this organization called CCEP. So we started this Wish Trolley project in March. And recently, we managed to do it in IPR Palliative Clinic. So they donated money and purchased these items, and hence we let the patient pick and choose what they want. So as you can see, this gentleman, he has lung cancer, and when offered the trolley, he can pick anything that he liked. He was so happy to have a neck pillow. And he chose a drink and also a nice thermal cup. Don't undermine the people who are not so young. Even pillows that have cute cartoons are a big hit with them. We actually have a bigger trolley for our onco patients. If you do have the opportunity, do drop by and join in the fun when we do the Wish Trolley project. Coming to our second patient, also another person that is very hard to forget, Mr. Jumat. He's a 60-year-old musician. He's an ex-smoker. He had goat eat COPD, and the IPR team referred to us in clinic. His COPD management has been optimized for years, and he requires oxygen concentrator at home. Most consults with him are inpatient for very simple reason. Before he can see us in the clinic, he's already admitted to the hospital. And because I do general medical specialist on call, I see him a lot when I'm on call. So with these frequent admissions, I don't get to see him in the clinic that much. In fact, in my 2-year follow-up of him, I only saw him 2 or 3 times in the clinic. The rest was when he was warded. And his admissions were as bad as once to twice per month, and each admission requires a few days up to a week. So he used to joke and say that hospital is his second home. So he was referred to hospice as his plan was to stay with his brother. However, there were 2 issues. The first issue, his disease was stable in terms that it's something that is a long-term, and he keeps getting admitted back into the hospital. So hospice also could not catch up with him on time, and whenever they made an appointment to see him, he was admitted. And there was a second problem. He doesn't want to stay with his brother anymore. He wants to go back to his own apartment. I was very curious. I asked him why. And he said that he missed his instruments. He's a musician. His home, his apartment, has drums, guitar, keyboard, flute, all sorts of musical instruments, and this brings him joy. Every day, the thing that he loves to do is to what we call jamming. He loves to jam, even when he's alone or when his friends come over. So whenever he gets admitted, most of the time it's an acute exacerbation. And every time he comes in, he comes with dyspnea. So this is very important, not to just give morphine. Sometimes when we get the history, there is fever, the phlegm is yellow, and hence we say that, okay, this is a pneumonia and he will need antibiotics. And in spite of that, in spite of optimal COPD management, his dyspnea continued to worsen. And we started to use aqueous morphine to control, and we slowly changed it to morphine slow release with breakthrough aqueous morphine in between. The question for everyone who's here, do you think morphine will make him die faster? Please post your thoughts in the chat box. So dyspnea, it doesn't mean that every time palliative sees a patient, whether they're in pain or dyspnea, automatically we will give morphine. That is very wrong. We actually need to investigate why is he having dyspnea. Is it a pleural effusion? Is it because of an infection? Or is it because it is truly because of the advanced disease? So like how Dr. Zainal said that, yes, it helps with dyspnea. So a lot of people are very fearful of morphine. One of the common things that I will say to patients is that morphine is a medicine. It's like Panadol. If you are not having fever, you are taking Panadol, then that is not the right thing to do. If you don't have pain, you don't have dyspnea, you don't have a life-threatening illness, you can take morphine. That is also not the right thing to do. But they who have chronic diseases that needs morphine to overcome symptoms, then it is called a medicine. So we start morphine when it is necessary. When it is not necessary, we don't start. It is not a routine of palliative. So dyspnea is a subjective experience of breathing discomfort. There is no objective way of saying that the patient, it's based on how they feel. It is not that, oh, they are breathing very fast, so it means that they are dyspneic. Or they are breathing very slow, it means that they are not. It doesn't work like that because this is subjective. So basically, how do we quantify such a subjective symptom? So we have objective tools such as visual analog of dyspnea scale or even the modified Bock dyspnea scale. So these are good tools so that we can estimate whether the treatment that we are giving is working. Sometimes, with a note of caution, people who are elderly or people who are frustrated, they may not be able to give you a number. That's why all these colors will help, and even the smiley or sad faces will help to give them an idea so that we can rate. So for dyspnea, of course, we must talk about pharmacological management. We are not just holding hands, we do more than that. So for dyspnea, if it is persistent and refractory, then we can start morphine and fentanyl. So for dyspnea, generally, we use a lower dose of 2 to 3 mg. We can start to give PRN. They take it when they're having dyspnea on exertion or 30 minutes before any activity. For example, if they know that they want to go out and they will feel dyspneic or they feel breathless when they go out, then before they go, they can just take morphine PRN. If let's say the dyspnea is persistent and occurs the whole day, then we can give Q4-hour, which is a regular dose. If there is renal or liver impairment, then we will need to adjust the dosage and also the interval. These drugs can be given via parenteral also, via subcut, intravenous, and also there's also transdermal patches. And also nowadays, there's also sublingual. And if the patient is very anxious, then we can also try to start some anxiolytics, such as benzodiazepines. However, please use low dose. Don't start with very high doses because that is causing harm. And many times they do have some mood disorders such as depression. So it's important for us to identify and also treat this with the right medications. So coming to non-pharmacological, pulmonary rehab is very important. Pulmonary rehab will help them improve their quality of life, which also will improve their symptoms. However, it's not very easy to follow through a whole regime. Oxygen support is useful, however, it's not across the board. For the disease per se, sometimes the patient will need it because it is a criteria. For example, if those who have pulmonary hypertension and have right heart failure. For our patients who are under palliative care, we will give them a trial of oxygen. If they find it useful, then we will continue. If they don't find it useful, we will not. Fan is a good tool because even as we feel the sensation of the fan, it will stimulate and reduce the breathlessness sensation. In a closed room, we will also feel very claustrophobic, very frustrated. So for these kind of patients, having an open window will be helpful. So I love the IPR setting because IPR it's sort of like open windows and there's a beautiful garden. So this kind of environment will be very useful for patients, and it is not just the wind, but also the scenery, giving a quiet and calm environment. If the environment is very noisy, next to the traffic light, a lot of cars moving, or people are very loud and talking a lot in shouting, or even next to a construction site, those are potential problems that can make a patient even more upset or even more frustrated. There are some other methods such as reading poems, reading exercises, mindfulness, prayer, meditation, dignity therapy, counseling, and cognitive behavior therapy. So it is my joy that in HKL, we do have quite a good team. Not only we have doctors, and recently also have 2 very big allied health palliative trained people that are our occupational therapists and also our physiotherapists. They have post-basic in palliative care, and they are really amazing people and make a difference in our patients' lives. So the question was, is morphine dangerous? Is morphine safe? Because a lot of people feel that taking morphine will cause respiratory depression, will cause apnea, and the patient will definitely die. So when they hear morphine, they will automatically stop. So previously in one of the centers that I worked in, it's very interesting to see, whenever I see a very advanced COPD, so breathless, I will start the morphine. And the specialist the general specialist who saw, was so frustrated and will cancel my morphine. And then after that, I'll go and see, and then I say, hey, you need morphine. And then after that, I write again, and then he canceled again. So this was something that is very common because the physician was truly very concerned for the patient. So I had a good lunch with this person, and we compared notes, and he slowly accepted, and now he is a big partner to help advocate for palliative. So in this particular study that was done in Netherlands, where patients were having COPD, they were started on regular morphine SR 10 mg versus placebo for 4 weeks. And what they found was improved disease-specific health status, and it did not cause any respiratory depression, nor dyspnea, nor apnea. It did not affect the PCO2, and there were no serious adverse events. And it also showed that the worst breathlessness improved when the MMRC was 3 to 4 rather than 1 to 2, which is something that we already know. So another study that was done in Australia is they use morphine SR, 20 mg OD compared to placebo, found that it had lesser rescue doses of morphine immediate release. So as you can see down there, a lot of them, about 50% of the patients that were studied were COPD. And this study showed that there was no respiratory depression. So back to the question, is morphine safe? Based on these studies, used at the low dose, right dose, it's safe. So coming to Ms. Encik Safa, he's a 50-year-old technician. He has ILD, interstitial lung disease, for a few years, and he was on OFEF. So he was referred to the palliative team in IPR, and he had dyspnea. However, the dyspnea was very not so common. It occurred only like every few days. So we didn't give him regular doses. We gave him a bottle of morphine. We taught him how to use it, and then when to use, when not to use. This is very important because one of the side effects of morphine is sleepiness. So some patients can't sleep at night. They take the morphine so that they can sleep better. So we have to educate them properly and say that this medicine is only for those that have breathlessness or pain. So the question, is morphine safe? I hope that based on what we have presented just now, that you will feel that morphine is safe, yeah? So his problem issue is the dyspnea. And this is a very important diagram, which I feel that we can understand the patients better. And since I started covering IPR palliative for the past few years, this is what I noticed, that this is the same pattern for most of the patients, where they will have breathlessness, and then they will be fatigued, they will slowly decondition, they'll do less activity, and social isolation. This is worse for those that are very extrovert, where they like to chat with people, where they like to go out, where they like to do things, or even for a lot of housewives that are unwell. To them, having meaning in life is to cook a good meal for the family, is to do all the housework, is to make sure that the family, everyone is well taken care of. So when they are no longer able to do this, they feel that the meaning of life has gone. Their dignity, they also feel so frustrated because the dignity that they felt was important can no longer be done. So many of them will go into anxiety, go into depression, and have reduced emotional well-being. So this is the slide that shows symptom prevalence in fibrotic ILD. So we can see over here that those with breathlessness, there's about 50 to 98%. And subsequently, those with mood disorder were the second most common, which were depression, anxiety, and a good 40+% have insomnia. The next common symptom is actually fatigue. So this is something that after seeing so many patients, this is something that is, I think based on experience, the number is actually higher. So again, what are the symptoms that also are present? It's not just dyspnea. There are many, many other symptoms. So if you're not sure how to do it, these are two tools that you can try, which is the ESAS and also the IPOS. IPOS will also give part, which is quality of life, and also a bit of guidance in terms of getting the symptoms. Yeah. So another part, so we talk about opioids. So now we know that based on whatever that I presented so far, that opioids look safe. So this is another study that was done in Sweden in 1,600 patients. So this is quite a good study because the number is so big. And this one, the focus was severe oxygen-dependent fibrotic ILD. So those who were on opioids were 254 patients. And this study showed that opioids was not associated with harm. And those who needed benzodiazepines were in 196, and they showed that low-dose benzodiazepines were not associated with mortality, whereas high-dose benzodiazepines were associated with increased mortality. So what is important to learn from this slide is that number one, opioids, don't associate opioids with harm. Number two, use low-dose benzodiazepines if it's indicated. So another of this study that was done in our neighboring country, impact of palliative care in end-of-life fibrotic in ILD patients. So in the palliative intervention group, they noticed that more patients had advanced care planning, basically planning what is important to them, less ICU admissions, more of them were prescribed with opioids, and this is the part where I found very interesting, where there is a longer median survival of 23.9 months compared to the usual group of 11 months. So some people still ask, is palliative important? I hope this slide shows that it is. So another study that involves 11 terminal stage IPF elderly patients who had dyspnea, it showed that breathlessness did reduce and there were no signs of respiratory depression. So coming back to Encik Safar, this gentleman whose dyspnea was gradually worsening and his fatigue was also worsening. So those with fatigue, it's important to control symptoms such as dyspnea so that they can sleep better. This is what I usually tell my patients. When they're in pain or dyspnea or any other symptom, let's start with the first goal, to achieve symptom control so that they can sleep better, so that their energy may improve, so that they continue to better and continue to fight their battle. We will teach to pace their activities and energy conservation strategies. So for Encik Safar, he loved to sweep. He loved to do household chores. This is a guy, he has wife, he has children, and he has daughters and sons and who are grown up, but yet he finds joy in sweeping and mopping his home. However, as he became more and more symptomatic and more tired, he could no longer do so. He bought a blower and started to blow his house clean. But after some time, he began to be more fatigued and his function was no longer like before. But he still wanted to do housework to contribute to the family, to help his family, because that is how he showed love. So next he started to do was to fold clothes or to help with simple household chores such as plucking the vegetables or cutting garlic and cutting onion so that his family can cook. So this is the last part of my session today, which is talking about goals of care, which is planning ahead. So interesting to note that those with progressive idiopathic fibrotic ILD, such as IPF, have short disease trajectory and also similar prognosis to patients with lung cancer. However, knowing this, but comparing those patients with ILD and those who had lung cancer, death was less likely to occur in a palliative setting for those with ILD. And they actually experienced more breathlessness, and also end-of-life discussions were less common. So when should we do it? So we should have to do it in we should do it at any point of time. At every time they are admitted, is always a good time to consider doing ACP or start all these critical illness conversations. So who should be the one to plan the last journey? Should it be the spouse, the children, or doctors just because we know better? Or should it be friends? Honestly, whoever is unwell, whoever is suffering, whoever is having the disease, that should be the person who should be doing the planning. So what is important? Prolonging the life. If they cannot accept, then we need to sit down and find out what are their goals in life. Quality of life, symptom control. What are their preferences? Do they prefer to be at home or in the hospital? And where do they want to be during the last hours? Who will speak for them when they can no longer make that decision? Are there any unfinished business? So these are some of my patients in the IPR clinic. So this is Mr. Syed. He has ILD. He's very clever. He and his wife are very resourceful. So he managed to find this little bag that can move around, and he goes around with this bag, and he went traveling with this bag, and he goes shopping. And he loves to go down every single aisle, and he moves so fast, his wife has to run to catch up with him. And cheekily, he told me, Dr. Lim, I had to turn around and tell my wife to walk faster. So this is how he's still enjoying his life, even though he has symptoms. Another is this lady, where she has cancer, but she's very clear what her goals are. So this is her daughter. And together, they make every day count, knowing that just because she has cancer doesn't mean that life stops. Another significant patient that I remember until now is this gentleman. He has motor neuron disease, but his biggest desire is to see his youngest child and only single child left married. So in spite of him being on BiPAP, he proudly showed me this shirt that he's wearing that he will wear on the day of the daughter's wedding. And together, we helped him attend the wedding and had fun during that time. Although he passed on not too long after that, but the family will have a lovely memory of him, remembering him with fondness and have loving memories of how they had a good time during that event. I love this statement that Dr. Rosalie said. Palliative care is not rocket science. Just do it. So like how Charlie Brown said, we only live once, Snoopy, but Snoopy said wrong. We only die once. We live every day. In summary, palliative care improves quality of life even in respiratory illnesses. Early referral to palliative helps them live their life to the fullest for as long as possible. Thank you.
Thank you very much, Dr. Lim, for a very enlightening session. And I invite anyone from the floor who has any questions to ask Dr. Lim or to write in the chat. So we have a question from Dr. Eugene on how would you want to initiate referrals to palliative care?
Yes, so there are many synonyms for palliative. Some of the synonyms are supportive care. So some of the words that we use are such as supportive care, comfort care, people who control pain, people who control breathlessness. So then we will go in and we'll see how the situation is. And then after that, we will explain what palliative care at the right time.
Yeah, I would also explain that it is also part of a medical subspecialty, just much like there is a respiratory physician and cardiologist as a specialist. So they would have to see that we are part of a bigger team. So maybe you would want to share with us what is your definition of a low-dose benzodiazepines. You've mentioned it in your talk. How would you initiate those in breathless patients?
So I guess we need to see what is the indication of starting the benzodiazepines. Sorry, yeah. So it really see whether it's during the day or during the night, and is it because of insomnia? Is it because of anxiety? Generally, low doses are like, for example, lorazepam, where we can start at 0.5 mg on night. So that is quite a good and low dose. So although on the labeling, it says that lorazepam is to only to be swallowed, but we have used it sublingually and it has worked. So these are good low doses to start with. Dr. Diana, what about you? What other benzodiazepines do you usually use?
It would be lorazepam as well, but then we do for those inpatients, sometimes we would give them a range of subcuts, midazolams at night, and then we discontinue it in the day so that they'll be able to talk with their families. So it is on a case by case basis. But we have a lot to offer patients. So please do remember the palliative care physicians in your patients with end-stage lung diseases, and we'll be happy to support you. So I thank Dr. Lim Siew Sian very much for your interesting talk, and I thank all of you present in the webinar today. And I will give the floor back to Dr. Eugene.
Thanks, Dr. Lim and Dr. Diana. Sorry, I was in the midst of typing a question actually, but can I just ask one question here, if you don't mind? Yeah, since probably speaking is faster than typing. So my question would be, in hospitals or in centers where you do not have a resident palliative care physician, and if you encounter patients who have got, a very end stage, COAD, for example, and a referral might probably take, 1 month for them to be seen. Are there any initial pointers or steps that you can probably share while waiting, to be seen by a palliative care physician?
When you say pointers, in terms of symptom control or in terms of initiating the discussions?
Symptom control. Probably maybe non-pharmacological, for example.
Okay. So if it's non-pharmacological, then like I mentioned just now, like having all the open windows, having a fan, those cute little handheld fans that are battery operated, those are actually very helpful. And don't underestimate the use of a fan. The wind actually stimulates the nerves, and it really reduces the breathlessness a lot. However, that is not foolproof. If you have tried many methods that is already not working, then perhaps you may need to start some morphine. Some of the things that I find very interesting is that these poems. So I have yet to see any Malaysian that find reading poems help. But in overseas, this is something that they find helpful. So these are also certain things that you can try. So our palliative physiotherapists and our palliative occupational therapists, there are actually quite a number of them around the country right now. Can actually ask them to help to guide, and they also can use a lot of breathing techniques, breathing methods. And also one of the ways is actually to start simple breathing exercises that all physiotherapists are supposed to know. One of the things is that when the breathing is become too tough, and every time you notice that in spite of you giving all your lama-laba or whatever medications that you're already giving and it's still not helpful, then the question will be, do you want to start a little bit of morphine PRN? So bear in mind that having morphine is not foolproof. There are side effects. Usually we will say that there are 3 major side effects. Number 1, they feel drowsy, they feel sleepy. Sometimes if they're elderly, they may even get delirium very easily. The second issue is 30% of them will have nausea and vomiting. So these 2 side effects usually will disappear within a few days once they get the regular dose. The third side effect is something that is quite significant and it doesn't disappear much. is constipation. So there is a saying that the hand that prescribed the morphine is always the hand that prescribed the laxative. That's a reason why we say that, to prevent it. So how do we start morphine? So morphine, for example, usually by the time they see us, it is never just breathless occasionally. But if it is just on exertion, for example, like they are even walking, for example, walking from house to the car or walking to work or doing whatever, they still feel a bit breathless in spite of your optimizing all the COPD medication, then you can start and tell them that, okay, let's try morphine, 3 mg. If they feel that, there might be side effects, or you feel that, okay, they're a little bit older, you want to start the lower dose, sure, you can try 2 mg, but tell them that the breathlessness won't reduce much, but it will help you get used to the side effects. Then once they are comfortable with 2 mg, then you can consider increasing to 3 mg PRN. And how frequent can they take? They can take up to every hourly. However, I will cap it, depending on the patient, I'll cap it to 4 times or 6 times a day. So if in spite of this, they are persistently breathless and using this regime, they find that it is not enough, and the breathlessness usually occurs during the daytime when they are walking more, then I will say, okay, then why not we take regular doses during the daytime? Because this group of patients will not have breathlessness when they are sleeping, because they are at rest, they are lying down, so they really don't need the morphine at night. So this is one way to do that. If the breathlessness is so persistent and they need it, then I will give regular dose. Please check the kidney and also the liver. If these two are okay, then you can start Q4 hour. If let's say there's renal impairment or liver impairment, please call the state palliative physician or the nearest palliative physician, then they will guide you on how to adjust the doses. And once you have achieved the regular dose, then we will sit and calculate how to give morphine sustained release or even fentanyl patch. Because to take medicine 4 hourly is very hard. To be honest, when I am unwell and I need to take antibiotics 7 days, for me to complete after day 5 when I'm already well, right, I struggle. And TDS dose by then, I probably will take BD. So what more our patients that have so many medicine. And one of the common things you hear is that, doctor, saya makan ubat lebih daripada nasi. So then we will try to reduce this polypharmacy and change it to sustained release morphine. Yeah. I hope that answers.
There's another question by Dr. Zainal, if you have time, Wadi Kafiq. Oh, one more question. How do you initiate the discussion on ACP and where would be the best time to do it? Or, yeah.
I think any time is the best time, provided the patient is ready. So it's not even, it's not a SOP, it's not an agenda. So recently I met this anesthesiologist that came and spoke to me, and I was like saying, hi, by the way, my name is Lim, I'm a palliative physician. And he said, who do you listen to? Yourself or the patient? I'm like, I listen to the patient and the primary team. We are a team that goes in to take care of the patient together. So hence, this is very important because we must understand from a patient's perspective and also understand from the treating team's perspective. We must achieve this sense of harmony among all before we can truly say that we are helping the patient live better. If the patient is not ready, then we shouldn't force them to have discussions, because we can potentially cause more harm, even though it is just a simple discussion. If they are not ready, then we will have to be a little bit more subtle and perhaps speak in a way that is not so intimidating, nor not so in your face kind of method, that we will just have simple conversations like we are having a chit chat or having tea, that kind of chit chat conversations, coffee conversations. And then when they are ready, only we slowly explain things to them and slowly see what is important to them.
Thank you, Dr. Lim, for that answer. And Dr. Zainal, I think on other positions, you can use the supportive and palliative care indicator tool to speak to see whether the patients actually need palliative care referral, and hence they would probably need ACP discussion initiated as well. So I think I will give this floor. Again, I thank Dr. Lim Shu Sian. Let's give her a round of applause from your screen, and we'll give it to Dr. Eugene. Thank you.
Yeah. So, to conclude, thanks, Dr. Diana. Thank you, Dr. Lim, for spending your evening with us. Certainly very enlightening and inspiring to hear from palliative care physicians. So with that, we will end our session today. See all of you again next week for our last and final session. Have a good evening, everyone.
Thank
Thank you all. Bye.